Okay, influenza. You're all pretty familiar with that. Affects elderly a lot. Anybody, again, who's immune compromised. Anyone in healthcare should have a flu shot. It does not guarantee that you won't get the flu because it's based on statistics of certain strains of the flu, but it certainly protects us from a lot of different kinds of flu. Usually the flu is a respiratory issue. Sometimes you have other issues, but when somebody has a GI bug, throwing up, diarrhea, runs a little fever, that is not the flu. That's a GI bug. The flu is respiratory in nature, usually comes on quickly with a fever, chills, myalgia or malaise, and a headache. When you have the flu, you are very, very sick. It's usually viral. The only treatment for it is to treat the symptoms, and then they will do an antiviral medication like Tamiflu, which does not help the symptoms, but it certainly helps the onset or helps the symptoms go away faster. Complications, the biggest complication, especially for aging people, is pneumonia. So you want to make sure that these patients are deep breathing, coughing, using incentive spirometer, anything we can do to make sure that their lungs do not get backed up. There are obstructive disorders involved in respiratory issues, including emphysema, chronic bronchitis, and asthma. All of these have similar components, but as you probably know already, they're all quite different. I like these slides. I think they are designed well because they give you kind of a good umbrella term. COPD is an umbrella term. It's the one we hear all the time. And then emphysema and asthma are broken down. And if you look in your textbook, I think it's page 651, there's a summary of COPD and the issues that go with it. But it's a group of pulmonary disorders. They're usually characterized by difficulty exhaling because the airways are narrowed or blocked by either inflammation or mucus. Maybe the fibers, the elastic fibers in the alveoli don't work, and the alveoli can become overinflated and they can't exhale well. There are three basic chronic obstructive pulmonary diseases: emphysema, chronic bronchitis, and asthma are the three main ones, excuse me. Chronic bronchitis, I love pictures, so this is a pretty cool one, but you will see chronic bronchitis. This guy is usually overweight. He's a smoker, barrel chest, just can't breathe. I think I told you about the guy who was my patient who drove from Washington, D.C. to the eastern shore of Maryland with a pulse ox of 77%. He pretty much looked just like this guy right here. And then the emphysema patient is this skinny little guy who just can't get his breath no matter what he does. So all of his energy and all of his calories go just to the simple work of breathing. Here's another slide that pretty much says the same thing. It talks about the blue bloaters and the pink puffers. And again, the chronic bronchitis guy is big, heavy, probably has cardiac issues. He's got all kinds of stuff going on. And he's just used to living on the edge as far as his breathing. And then the skinny little guy just struggles to breathe. Either one of these, by the way, you might see outside of a facility with oxygen in their nose, and they take the oxygen out and then they smoke a cigarette. Yeah, it happens. It's really horrible when it does, but it does. So, what's the pathology? Chronic bronchitis is similar to regular bronchitis that we've probably all had, except people have it all the time. So to be diagnosed with chronic bronchitis, you have to have it at least 3 months of the year for 2 years, multiple exacerbations. I'm not going to read the slide to you, but the bronchial tree becomes inflamed. So, and there's no way to reduce the inflammation. And the ciliary function dies. Ciliary function means the little hairs that move things around within your lungs, those die, and then mucus develops. And it's like a chronic infection. Very uncomfortable. Emphysema. This affects like the bronchioles and the alveoli, the farther parts of the lungs. The alveoli walls, they lose their elasticity. So just imagine a balloon that gets full of air, but because it's not elastic anymore, the air can't come out, and gas exchange is then impaired. And here again is another picture, and I'm not sure how big your screen is, so I hope that you can see these well. If not, you might want to blow it up, but you can see the normal bronchial tube and then an inflamed, obstructed bronchial tube. So, and look at the alveoli. Here's the normal alveoli, all these little tiny ones, and then here's the big overstretched balloon. So I think that gives you a good idea of what those disease processes are. COPD usually comes from smoking or secondhand smoke or air pollution or chemicals. Occasionally, there's a familial thing to it without any of the environmental things, but that's pretty rare. It's almost always some sort of inhaled irritant that causes the cascade for any kind of COPD. I like this, you know how I am about pictures, but you start here and you're short of breath, and then you get anxious, and then you start breathing shallowly, and then your muscles tense up. And wait, that only makes you more short of breath, and then you get tired, and then you don't have any energy to do anything, and then you get more anxious because you can't do anything, and you get more short of breath, and then you become more anxious, and on and on and on and on and on. So this patient's kind of miserable. Asthma. You will see asthma in all ages of people. In little people, it's usually caused by allergies of some sort, and an allergy is just nothing but a lung irritant. And an asthmatic patient hypersecretes mucus. So again, imagine Elmer's glue in the alveoli of the lung. Um, the alveoli become inflamed, they swell, the bronchioles swell because of all of the irritation, and then that very hollow, normally hollow, patent tube becomes narrowed. So again, take a balloon, suck it up at the edges, you'll hear the wheezing, and you'll understand what happens with asthma. This is a really good diagram and a good algorithm of what happens in asthma, what the early phase response to an asthmatic episode is, and what the late phase response is. Of course, we want to keep with the early phase and get it remedied as soon as we can. First sign and symptom of an asthma attack is shortness of breath, wheezing, sometimes heard without a stethoscope. That's when you can hear something without a stethoscope, it's considered audible. So an audible wheeze would be you walk in the room and you hear eee! You know you have a problem. Diaphoresis, because the person's working so hard to breathe, they start to sweat. After the attack, the asthma attack, they might have a good thick expulsion of sputum. I know that sentence alone makes everybody feel really good. And the patient will feel like they're suffocating. So we got to get their lungs open really, really fast. And first thing we need to do is eliminate the trigger. So if it's an allergic reaction, stick that kid in the shower, and you're going to use bronchial dilators, basically beta blockers, albuterol. You're going to use steam inhalation, and then when it gets severe, they're going to use corticosteroids. So it's very easy, especially with a child, to put them in the shower while you're giving them a bronchial dilator. And it works really well. Do it at camp all the time. What you have to do with asthma is reduce their anxiety, because the more anxious somebody is, the more chance they have to breathe improperly, even with a healthy lung capacity. I think one of the most important things for asthma, and again, especially in children, but even in young adults, is to teach them the signs and symptoms so that they can handle the asthma attack on their own. Most kids, it doesn't take them very long to know they're not breathing well, and they will ask for their inhaler, or they carry their inhaler with them, and they can treat themselves very quickly. Asthma for kids is the most probably prevalent childhood illness. Again, they are taught to use the peak expiratory flow meter. They also are taught how to use their inhalers very early. Sometimes children and elderly people have to use a spacer with an inhaler, and that is a pretty cool thing because it's hard to teach a child to um, push on the inhaler, suck it into their lungs without swallowing it. So sometimes they will use a spacer. So they push the inhaler, the drug goes into the spacer, and then they suck in from there, and that's pretty effective. If a child or an elderly person is prescribed a medication like an Advair disc, they do not fit on spacers. They don't work that way. So sometimes that is a complete waste of a lot of money. So you have to really advocate for the patient to get the right drug in the right format. Now we're going to talk about pleural effusions and atelectasis. A pleural effusion is an abnormal accumulation of fluid in the intrapleural space. So that is between the lung and the chest cavity. So your lungs are covered with a membrane, and that membrane has fluid in it, and that fluid works to keep the lungs supple so they can breathe it. It's like a lube. And if that becomes too mucousy or too viscous, too thick, again, Elmer's glue, then an effusion can develop, which means more fluid gets in there and that packs down the lungs' ability to breathe. Fluid can be either if it's exudated fluid, it can be removed with either a chest tube or a thoracentesis. And when you do a thoracentesis, you're the assistant to the doc, and basically you hold the patient still, and it's a sterile procedure where the doctor puts a needle into the pleural space and sucks out the fluid. If the pleural effusion is consistent and not a one-time deal, then they have to put in a chest tube, and then the chest tube continually sucks out the fluid. You can see here just a sample of a pleural effusion. Here's a little one. This is a bigger one. This one might require a chest tube to be put in right here. This one, they would probably see what the cause of it is and let it remedy on its own. But if the patient is really having a hard time breathing and the fluid's not dissipating, then again, they'll do either a thoracentesis or a chest tube. And here's what a pleural effusion looks like on an x-ray. This is a bad thing. This means this lung is pretty much smashed in and isn't getting any air. So the rest of the lungs can do it. The patient's still okay, but there's probably major discomfort with this x-ray right here. And then atelectasis. And this is where the alveoli collapse. I talked about this a few minutes ago. This can be caused by a lot of different things. It can be caused by aspiration of vomit. It can be caused by a tumor, an aneurysm. Sometimes it's a complication after surgery. It's diagnosed with chest x-ray. They do ABGs to see how bad it is and how the patient's tolerating the limited lung space. With all of these issues with the lung, nursing interventions are usually the same. We want to prevent it. Coughing and deep breathing after surgery, incentive spirometry, auscultating breath sounds. Anything we can do that is going to give us a heads up will be good. And you can see right here, here's the atelectasis right here. And it's just junk that has to be cleared out. And we've already kind of talked about PEs when we've talked about the cardiovascular system. So I'm just going to run over them really quickly and what causes them. But pulmonary embolism and pulmonary hypertension are going to be in the next video.